Great. All right. Well, thanks so much for having me here. It's fun to be back again. The case is about delirium, technically. I mean, it's delirium in the setting of dementia. So we will try to focus on both of those conditions, and I'll try to come back to the core theme about how to think of both simultaneously and the importance of not confusing dementia with delirium. But for the purposes of this little talk to begin with, this is primarily just about management of agitation in dementia, although the same principles apply in delirium too. So a little question for the group here. So how many FDA-approved medications are there for management of agitation in dementia? Right, got a goose egg over there. Absolutely. So this is the key. And is it for lack of trying, do you think? Like nobody's wanted to do this? No. And when I went through just for kicks once and searched PubMed for agitation dementia medications, and there's like 70 different medications that have been tried, everything. And so that in itself is the take home here. There's no good approaches based on the evidence, and pretty much everything is off-label use. So that's probably the key take home. So if you've got somebody who's got agitation, behavioral problems in dementia, don't think medications first. And then just in case you happened to be unaware of this, there's a very important black box warning. It's not often I get to talk about black box warnings in psychiatry. But sure enough, there is one for pretty much all the antipsychotics in the setting of dementia. So this is the text on the actual black box. And if you want to read it for yourself, just so you'll remember, basically there's a lot of trials, and what they found consistently was that patients who got antipsychotics in the setting of dementia had about 1.6 times increased risk of death. So this is not a minor side effect. This is the real deal. It's hard to go back from death. And interestingly, it wasn't one particular cause of death. It was across the board. So it's not like you can risk stratify people and say, oh, they're not going to have cardiovascular events because their heart is totally fine. This was pretty much everything. So this is probably the most important cover yourself advice here. If you're going to use antipsychotics in somebody with dementia, you need to document an informed consent discussion with the family. There's many lawsuits I have heard about, and I think there's going to be more where the obvious happens. Doctor, did you know about this black box warning? Yes. Did you prescribe this medication? Yes. Did you talk about it with anybody? No. Did the patient die? Yes. And it's you can follow the logic. So for your own safety and well-being, be very careful about this. And if you're going to prescribe antipsychotics, make sure you document carefully. The current recommendation, which we come back to later, is to use the lowest possible dose for the shortest period of time, and then I'll present an alternative. So the key, instead of medications here, really is to understand the behavior. And this is frustrating to me as a psychiatrist, because when I talk to the residents about agitation and dementia, I'll present a little case and say, you got somebody who's all agitated, and they're screaming out, trying to hit people. What do you do? And people raise their hands like, Haldol. Somebody else will be like, no, I'm going to give them Risperdal. And I would say, no, stop, everybody. Before you throw pills at somebody, why don't you think about what's going on? And it's unfortunate we don't spend more time talking about how to understand agitation as a behavior, but there is, in fact, a good theory about this. And once you get an approach, you really can start to figure out what might be agitating people and start to figure out approaches that will help them. So I'm going to very quickly go through this, and I encourage you to at least to have a rough framework that you keep in your head. So delirium's the first one. We'll be talking a lot about that. Second issue, huge issue in older populations, especially in institutional care settings, is unmet needs. So what would some of the unmet needs be? Somebody has bored. So boredom, lack of things to do. Hot, cold, thirsty, poopy diaper, in pain, if you can't see things clearly, if you can't hear. So any number of unmet needs. And what you have to realize is if somebody doesn't have dementia, they'll probably either act on them to fix them or tell you about them. But in a person who's got dementia, they're not going to be able to articulate that. So in England, for instance, they've used treatment with analgesics for people with dementia and found that rates of agitation go down just presumptively treating pain. Once you get a handle on unmet needs, a lot of the agitation goes away. Some folks I know who work in nursing homes will say that if you can figure out unmet needs, about half the cases of agitation are pretty quickly addressable. The next one is on conditioning, and this one's a little harder to sell, but even if somebody has significant dementia, the human overlearned behavior of doing something that gets a response continues. So you're in a care facility with one nurse's aide for 40 people, and you're left alone all day, and you don't like that, but if you hit somebody once in a while, you get more attention, that kind of behavior is going to continue. There's even great cases of classical conditioning. Real quickly, a case of a guy who kept slugging people in the nursing home at random. They couldn't figure out why. Finally, they found that he had been a boxer, a prize fighter, and every time he heard the elevator bell go off, he'd hit somebody. So they moved him away from the elevator, and everything was fine. And then finally, what we call natural response, which is if you could see the world from the patient's perspective, you would probably be agitated too. So you're sitting here, somebody comes at you and tries to take your clothes off you. What are you going to do? You're going to protect yourself and save your space. And the patient doesn't fully appreciate that you're trying to give them a bath or help them. So if you could see the world from their perspective, a lot of the agitation would be seen as being natural. So when you really do a behavioral analysis and understand agitation as a behavior that happens in a context, a lot of automatic and natural treatments appear or ways of mitigating the agitation, and then you don't even need to take other steps. Nonetheless, there's going to be cases where somebody is agitated, and I'm going to try to sell you real quickly on the idea that we have an alternative to antipsychotics, and that is prazosin. So any of you seen using prazosin for agitation? A couple folks here. Relatively new. Our VA promoted this for PTSD treatment, but we've had a huge amount of success using it for agitation in the setting of dementia. There's one good study by Lucy Wang, W-A-N-G, and they're doing another study. This is, from my personal experience, the only pill I give out in clinic where families come back and say, you can stop the rest of those pills, but don't take away that prazosin. So it really does seem to help. And when you think about what it is and how you can sell it, it's an adrenaline blocker. And that's basically what it does as an alpha antagonist. So people in dementia have too much adrenaline in their brains. You use a blocker for it, and it takes the edge off. Certainly doesn't fix the underlying problem, but at least it can help deal with the hyperadrenergic state that they're in. So the way we started is about 1 milligram twice a day. Prazosin doesn't work as an antihypertensive until you get to about 15 to 20 milligrams total, and even then it doesn't work very well consistently, which is why we don't use a mini press to treat blood pressure. So the dose ranges really are lower than you'd expect much orthostasis or consistent drop in blood pressure from. Then you increase doses in increments of about 1 milligram until you get to about 4 twice a day. A lot of people need less than that, and then if you need to go higher, that's fine. And some families have found that PRN dosing works, especially during transitions. But over time, most everybody is able to get on a pretty stable, scheduled twice-a-day dose, and it really can work. And then if you find you need antipsychotics, just a reminder to try to use the lowest possible dose for the shortest period of time. Even people who are enthusiastic about antipsychotics have published this lately, given both the black box warning and also the fact that when you look at the studies, they're not all that effective. So I realize that's a very quick and dirty approach to agitation and behavioral problems in dementia, but what I would strongly encourage you to do is think about the behavior first, try to figure out why it's going on, especially looking at unmet needs. And then if you can't figure out a way to fix it and you've looked into all the possible behavioral approaches, then to turn to medications. So that's a quick rundown, and I'm happy to come back to this theme later, or we can focus on delirium.